All right. Well, thank you very much, Neil and Wally. I really appreciate the kind invitation to participate in your lecture series for the Center for the Institute for Successful Longevity, and I'm really glad that that everyone is here this afternoon. And thanks for attending. And I'm happy that this virtual visit worked out. I, of course, would have preferred that I could have made it down to Tallahassee, particularly when I woke up this morning. It was 34 degrees here in Maryland, but I'm glad that we were able to make this work. So I'm going to be talking this afternoon about preventing cognitive decline, Alzheimer's disease, dementia, and looking at some of the evidence for cognitive training. Okay, you can advance the slide. And I have no disclosures. I want to acknowledge my current research. It's funded by the National Institute on Aging. And I thought we would start out by trying to address the basic question of what is cognitive training. There's a lot of confusion out there, not only amongst the research community, but people who are thinking about doing cognitive training. And what I mean by cognitive training is not just puzzles or brain games, not just brain training. It has a specific meaning, and a lot of times we use terms like cognitive training and cognitive rehabilitation and remediation somewhat interchangeably, but I think there's a specific meaning, or at least I'm going to use it very specifically here to refer to guided practice on a set of tasks that are related to memory, attention, and other brain functions. You can train on a single ability like memory, or you could cross-train on multiple abilities like memory and reasoning. Training can be top-down. By that I mean that it can be strategy-based training, or it can be from the bottom up, focus more on the process. It can be compensatory, where we try to compensate for a deficit, or it could be restorative. It could be delivered via computer, or it could be delivered in person, either to an individual one-on-one or in small groups. And it's based somewhat loosely on the idea of neuroplasticity, that there's potential modifiability, that this training can result in cognitive improvements. So why is cognitive training in later adulthood important? Well, I don't need to tell this audience that the population of older adults is growing rapidly. We have 20% of the US population projected to be over age 65 by year 2030. And there have been studies done, such as this study in 5 countries by the Harvard School of Public Health, that looked at things that people fear most about growing older. And in this particular study, they found that dementia, next to cancer, was the most feared aspect of growing older. And there have been other surveys like this that have been done, national surveys that show that cognitive impairments are a major worry of older adults. And there's also been a lot of disappointment in the drug trials that have been done to date. So I think there's been interest in moving from more pharmacological interventions towards these non-pharmacological interventions involving things like cognitive training. We also know that cognitive impairments heavily affect the older population. It's been estimated from the Adams study that something like 1 in 4 older adults past age 70 have an impairment without dementia. And upwards of 5.7 million people in the US have Alzheimer's disease, and that's probably an underestimate. And that there are disparities in the prevalence of Alzheimer's disease, with African Americans, Hispanics having higher rates of Alzheimer's than white individuals, 2 times and 1.5 times respectively, in terms of the rates for African Americans and Hispanics. So this survey that came out of Canada involved over 2,000 Canadian women age 55 to 95, and it's called the WOW study. And this is an acronym for What Older Women Want. And in this particular study, they had older women identify areas that are major health priorities for them. And then they asked them whether this problem was being addressed by their physician. And you see here on the slide that the problems like cancer and stroke and cardiac disease, also diabetes, are problems that are concerning, but they're also problems that these women felt were being addressed by their physician. The problem that most women, though, identified as a priority was memory problems. That was the highest priority mentioned, and that was pretty much true across this age span that they studied. And what was interesting here is that this was a problem that was the highest priority, but the one that was least likely to be addressed by their physician. So there seems to be this disconnect in terms of cognitive problems and those problems actually being addressed, which I think represents an opportunity for intervention approaches and certainly an opportunity for cognitive training. Oops. So next slide. So the AARP has done some national surveys of willingness to engage in cognitive training, and this was done with over 1,600 older adults, a national sample. And you'll notice from the data here that the majority of people, both men and women, various ages from age 40 up through age 70 plus, and working and retired, are willing, their state of willingness to engage in cognitive training. So they asked them the question, if you wanted to improve in a specific area related to your cognitive ability, how willing would you be to participate in cognitive training? And the majority of them, 82%, said they were very willing or somewhat willing to participate in cognitive training. Men, somewhat less willing, and people who are retired, somewhat less willing than those who are still working. So next slide, please. So about 3/4 of the adults in that survey said they would be willing to spend 16 minutes or more per day on cognitive training over a 6-week period of time. And notably here, over 8 in 10, 85% of African Americans stated that they are willing to spend 16 minutes or more per day on cognitive training. So this survey certainly has cause for optimism in terms of people's willingness to engage in cognitive training. But of course, this is by self-report. We don't know if people are actually going to go through with actually signing up for a cognitive training course. There was an interesting study out of Florida State University with Walter Boot and his colleagues that explored this question about individuals' willingness to engage in cognitive training. And they found in that, and this was a series of studies, through these studies, that people who perceived cognitive training to be more efficacious, the more efficacious they perceived it to be, the more willing they said that they would be to engage in the training. And there was also more willingness, you were more open to experience, and if you had more perceived cognitive deficits. So there are different factors that might relate to people's willingness to actually do this type of training. So this figure that you're looking at now is from a review that Marion Zhuang and her colleagues did at Johns Hopkins that reviewed the the literature on the percent representation of ethnic racial minority groups in cognitive training. And they surveyed over 30 studies in the literature, and what they found was that that there were only a small handful of studies, including the active study that Dr. Boot mentioned. There was a study senior-wise that Graham McDougall has led that had a sizable proportion of African Americans and also Hispanic, Latino, older adults, which is, I think, the only study in the literature really with that group represented. And most of the other studies had very small percentages of ethnic racial groups represented. And in fact, fewer than 50% of the studies even reported the ethnic racial composition of their participants. So this is an area that where we really need to have more representative samples, diverse samples to engage in these cognitive training studies. So on this next slide, you see this is a report that came out a few years ago that was done by the Alzheimer's Association. They were commissioned by the World Dementia Council to review the literature at that time on the modifiable risk factors for cognitive decline and dementia. And as you can see here, there are many factors at increased risk for cognitive decline, including things like midlife hypertension, diabetes, history of depression, sleep disturbance, and so on. And then there are some protective factors that help to decrease risk for cognitive decline. And you see things like years of formal education, physical activity, and you also notice there cognitive training. And from their review of the evidence, they concluded that there was moderate evidence at that time that cognitive training was protective against cognitive decline. So that report came out about 5 years ago. There was another report from the National Academy of Sciences that was published in 2017 that was commissioned by the National Institute on Aging, and it reviewed the evidence for intervention benefits. The title of the report was Preventing Cognitive Decline and Dementia: Way Forward. And in that report, they identified three beneficial effects of three classes of interventions: cognitive training, blood pressure management, particularly in midlife, and increasing physical activity. And their conclusion was that there was moderate strength evidence for cognitive training, and that evidence was based largely on the active trial, which has really become, I think, sort of the gold standard for cognitive training trials in this area. So on this next slide, you see a quote from that National Academy's report. In conclusion, some randomized clinical trial evidence based largely in the active trial suggests that cognitive training can improve long-term cognitive functioning and maintenance of independence of instrumental activities of daily living. This is inconclusive but encouraging evidence, and it supports public health communications about cognitive training as a tool for delaying or slowing age-related cognitive decline. So they said it's a very encouraging evidence. They stopped short of recommending any particular cognitive training program, but at least they thought we had reached the stage where it merited these public health communications saying that this is a promising tool. So one of the really vexing problems, I guess, we have in this area is this that training seems to work sometime and not at other times. So is it working? Is it working? Is it not working? And we kind of go back and forth. And I know this is certainly frustrating for those folks in the public who are trying to make some sense out of all of this and trying to make some decisions about whether to actually engage in a cognitive training program. And it's frustrating for the researchers as well, because it just seems that, you know, one report comes out that supports the efficacy of this training, and then another report comes out that that disconfirms the efficaciousness of cognitive training. And so we kind of go back and forth in this cyclical pattern over time, and hopefully we'll be getting out of that at some point, but we're still sort of going back and forth deciding, does this training really work? And that's maybe not the right question to ask, as I'll talk about later, that really maybe the more important question is, for whom does the training work best and under what conditions? So, but this has certainly been a problem in this area of research. And there's different reasons, as you see here in the next slide, for lack of study consensus. And I won't go through all of these here, but I think one of the main reasons is underpowered samples. A lot of times these intervention studies are expensive to conduct, and so the sample sizes often are very small, and a lot of times the training is underdosed, and that people need more training than just, you know, 1 or 2 doses of the training. And you know, it's always important to keep in mind that cognitive training is not like a cognitive vaccine. It's not like you get one sort of dose of the training and then you're, you know, immune to all cognitive decline afterwards. You need often prolonged dosage and maybe even booster dosage to you know, see sustained effects. So that's certainly been a problem, and failure to consider individual differences. You know, for whom does the training work best? That has not been addressed as much as it should be. There's problems in terms of deciding, you know, how the training generalizes or transfers to beyond what you're being trained on, and there's different problems in terms of identifying what's called near transfer and far transfer. And I'll get into that a little bit more later. And just generally, poor communication about study methodology and terminology in this area. So there have been lots of meta-analyses done to date that try to, you know, compile data across many studies and try to come to some conclusions. And the meta-analyses disagree. And we've published some from our lab. There's the Simons paper that came out a few years ago that Dr. Boot and Dr. Charnas were involved in, that raises some very legitimate questions about the efficacy of cognitive training and how to improve best practice in this area. And so there's still, you know, not total agreement in whether or not cognitive training works and for whom it works. So there's, I think one of the main questions that has to be answered here is, can we improve cognitive function, prevent cognitive declines, and reduce health disparities in older adults through cognitive interventions? And so what I'd like to do is to spend the next several minutes discussing the evidence for cognitive training effects with older adults. And I'll be drawing primarily from the active trial here that Dr. Boot had mentioned earlier. So active is an acronym. It stands for Advanced Cognitive Training for Independent and Vital Elderly. And it was co-funded by the National Institute on Aging and the National Institute of Nursing Research. And it was a very large-scale intervention trial involving over 2,800 older adults from 6 sites around the country. And you see the 6 sites listed here. And Active, as you see in this next slide, has been running for 25 years now. It began in the mid-1990s when the trial was funded at these 6 sites. And then in the late 90s and early 2000s, we ran a 4-condition or 4-armed randomized control trial, and then did 1 and 2 year follow-ups during this time. And then from 2002 to 2010, we did 5 and 10 year follow-ups and published papers on those follow-ups, 2 and 5 year outcome papers. And then the 10-year outcome paper was published in 2014. And currently, in the last 5 years, we've received funding from the National Institute on Aging to do a 20-year follow-up of the active study. And we are doing a data linkage study. We're not actually out trying to relocate and retest active participants, but we're taking data that we've collected through 10 years of the study and linking it to large secondary databases like Medicare claims records and credit histories and state driving records and the National Death Index death records. And so that study is in process. We have gotten all the databases except for the credit history database, which we're hoping to get shortly. And we should soon have some really exciting results coming out of that work. And we also had a supplement on race and social determinants of health for active that was funded by the National Institute on Aging. And there'll be a special issue, hopefully next year sometime, coming out on race and social determinants of health and how they impact on cognitive changes and cognitive training effects in the active data set. This is in Journal of Aging and Health. So on the next slide, you see the design of active. The basic question we ask is, if we train on basic cognitive abilities like memory, reasoning, and speed, which we know decline pretty reliably with age, does that transfer to real world tasks like managing your medications or managing your finances or preparing meals or driving? And so we randomized individuals into one of these 4 training groups here: memory, reasoning, speed, or no contact control. We did booster training at 1 and 3 years after this initial training. And then we had a series of follow-up tests beginning at 1 year and running through 10 years of follow-up. And you see here on the right-hand side of the slide, the mean age was almost 74 at baseline, with a pretty wide age range up to 94, about 3/4 female, about 26% African American. And they tested cognitively normal. And that was one of the inclusion criteria. You had these were community dwelling individuals who did not have cognitive problems at baseline. And again, there are over 2,800 people involved. So just to give you a little bit of sense of the active cognitive training, there were 3 intervention groups. We had a memory intervention group that focused on verbal episodic memory, and we taught mnemonic strategies for remembering words or word lists or main ideas in a story or in a conversation. And here you see a snapshot of Memory Man. This was part of a technique called method of loci, where people memorize locations on a person's Memory Man's body and then use those locations to pair words that they wanted to remember, items they wanted to remember, with the location on the body. And this is a very powerful technique that's been used for many, many years, and it seemed to work very well in the active trial. And there are a lot of other memory strategies that we taught people, such as categorization. The reasoning intervention involved trying to solve problems that follow a serial pattern. And so they practiced strategies for doing that on things like letter series, where there were changing letters and you had to identify what the pattern of letters was. And we also had real life tasks like trying to manage someone's medication schedule. And here you see someone who's taking multiple medications every day of the week at different times. And so you had to identify patterns in the schedule of medication taking. And then speed was a computerized test. It was still done in small groups, but each person at a computer station. And it involved basically something called the useful field of view, where you had visual search skills involved in a divided attention environment, and you had to identify a target in the center of the screen, in this case, either a car or a truck, and then there were distractors around the periphery of the screen, it was an assessment of how quickly you could respond to the target and ignore the distracting information. And then we had a no contact control who just received the different measures, but none of the training. So there were, in this next slide, you see the 3 levels of training outcomes in active. We trained in the basic cognitive abilities, as I've mentioned, memory, reasoning, and speed. Our major interest was outcomes that related to everyday functioning, like independent activities of daily living, and then downstream effects on secondary outcomes like health-related quality of life, mobility, and health service utilization. So this is just a graph of the active conceptual model and then we also modeled individual differences that would predict how well people actually respond to the training. So these figures show the training effects at 10 years. And you'll see here that all 3 interventions did better than the control group in terms of training effects that lasted 10 years. And those effects at 10 years were significant for reasoning and speed. They statistically trended for memory, but fell just short of significance. You see overall, there was some decline over time, but the people who were in the memory and reasoning and speed group had less decline than people who were in the other conditions where they weren't trained on those abilities. As I mentioned earlier, we also had booster training, and this was training that went above and beyond the initial training, and boosters made a difference, particularly in terms of reasoning, training, and speed. If you got this extra training, which didn't really involve any additional strategy instruction, but just more practice on what people had already learned, it resulted in improved reasoning and speed outcomes versus people who didn't receive a booster. So active, I think, is one of the only studies that actually did multiple boosters. We had boosters at 1 year and 3 years post-training. So as I mentioned, we're very interested in the instrumental activities of daily living. And here we see at 10 years that relative to the control shown here in the burgundy line, all 3 of the intervention groups reported fewer difficulties carrying out their everyday activities of daily living compared to those in the control group. And so we were quite excited about those results, showing that there was some generalization beyond just the cognitive abilities that they were being trained on. And you see here on this next slide that there was also transfer to other aspects of daily functioning involving things like mobility of driving, beliefs in internal control, fewer depressive symptoms amongst those people who had been in the speed training, and better health-related quality of life and reduced healthcare expenditures for folks who had been through the training. So there was evidence, some evidence here at least, for transfer of this training beyond just what people were trained trained on. So the question that we ask ourselves and everyone asks us is, why did the active cognitive training work? Particularly when so many of the other programs haven't shown as promising results. We're not sure exactly why, but we have some reasons why we think it did work well. It was all in-person training in a group. There was a lot of active engagement and learning exercises. We had a focus on real life examples, and we spent a lot of time in active. I think unlike a lot of other training studies, really emphasizing how the trained strategies could be used to help solve problems in people's everyday lives. And this was really a deliberate part of the active training, and I think it really helped in terms of the transfer that we did see. And we did have these multiple booster sessions, as I mentioned. We had multiple practice opportunities. So at the same time that seems to be working, there are many unknowns. And we don't really have an agreed upon protocol for cognitive training, which is very similar to what we see in the physical exercise field. We don't really know how much training should be given, for how long, for whom does it work best. Are we even targeting the right abilities? Why do we still see very little generalization to everyday functioning? And can the training prevent dementia, which is certainly a key question that we want to try to address. So in terms of the question of how much, the dosage really matters. And in physical exercise, nobody says just do 10 hours of exercise and then just stop what you're doing. In active, if you look over 5 weeks that they're doing the training, it's really less than 900 minutes of training, less than 2% of their available time during that period. And over the 10-year period, a very small percentage of their time was spent in training. And so it was a very modest dose of training, even though we're able to demonstrate these longer-term effects. The training the dose was not that high, and that's been a problem for a lot of other cognitive training studies as well. And as you see next, the dose matters, and adherence to the training protocol matters. This is a study looking at adherence to the memory training protocol, and people who you see the light gray line there at the top, people who adhered to both the initial training and the booster training. This meant that they completed at least 8 of the 10 of the initial sessions and 3 of the 4 of the booster sessions at each time of the booster training, compared to the people there at the bottom who completed fewer than 8 of the initial training sessions. They performed better on the memory tests than people who had adhered to the training. And adherence has been a real challenge in this area, even though I'm happy to report that in active we had over 90% adherence to the training, and meaning that
Hello. Yep.
90% of the people completed over 80% of the sessions. So we also, as I said, screened for cognition at baseline, and people tested cognitively normal, but we had some about 200 people at baseline who were MCI-like. They did poorly on the memory test at baseline, and we looked to see whether or not this subgroup of participants would benefit from the interventions. What we found is that the MCI subjects did not benefit from the memory training, but they were able to benefit from the reasoning and speed training. I think these findings differ somewhat from some of the other findings that have been reported. Dr. McDougall in his senior wise study published a paper a couple years ago showing that senior wise people, subgroup who were MCI in senior wise did benefit from that training, but for whatever reasons, that memory training didn't seem to it attenuated the effect if you were MCI like at the baseline. And then in this next slide, these are data that were presented at last year's GSA symposium by Cynthia Felix, and she's very interested in the effects of depression on training outcome. And what you see here is memory, reasoning, and speed scores, a change over the 10-year period of time, stratified by intervention group and depressive symptoms. This was on a self-report measure of depression called CESD. And you see here that the slopes of the change are fairly similar across groups, but there are intercept differences here, meaning that the people who are non-depressed tended to do better than the people who reported depressive symptoms. And that was true in the training groups as well as the control groups, but even people who reported depressive symptoms seemed to be able to benefit from the training, but they started typically at a somewhat lower level of in terms of their memory scores. This is memory score change. Next, we've also looked at racial disparities in training gain. As I mentioned, we've got about 26% of the active sample African American, about 700, over 700 older African Americans who took part. And we published a paper on external locus of control, which is looking at outcomes as being determined by fate or powerful others. And that external locus of control is higher amongst our African American participants. And as you see in the next slide, that African Americans who were high in their external locus of control made fewer gains in their reasoning scores after they went through reasoning training compared to non-Hispanic whites. And the same was true with the memory outcomes as well. And so this raises the possibility of maybe targeting locus of control as a target in cognitive training to improve locus of control or change locus of control that might then impact the way people view the training and maybe in terms more of their own efforts rather than chance or powerful others. So the next question that I'd like to try to answer would be to look at whether cognitive training slows mental aging and prevents the onset of dementia. And this is a question that's been around for a while. It's been a high priority. And we really need a well-designed trial to try to answer this question. ACTIVE was not designed as a dementia prevention trial, even though we've tried to look at the issue within ACTIVE. And this next slide, you see we took the ACTIVE participants and looked at incident dementia and looked at survival analysis over 5 and 10 years to determine whether active type of training had anything to do with slowing down new cases of dementia over time. And as you see next, we did not have clinical diagnosis of dementia. We didn't bring people in and examine them and have a consensus conference about dementia, but we did come up with some empirical definitions and we had several different ways of defining dementia. We did a sensitivity analysis. All of these in different combinations seem to work about equally well, but it's not ideal, but this is sort of the best we could do in terms of our definition. And so using that definition, as you see next, if we look at incident dementia by treatment groups, overall, when we collapse all the treatment groups, the next to the last column there on the right, the incident rate per 1,000 person years is 17.4 versus 19.2 in the controls. So a reduced incidence of dementia by treatment, although it fell short of significance, but it certainly was encouraging that we seem to be moving in the right direction here. And next, you see the survival curve here. You see some separation between the training group and the control, but there's also a lot of overlap. So it just wasn't enough to make a difference here. This is dementia-free survival probability. And Jerry Edwards, in a paper that came out in Alzheimer's Dementia, looked at the 10-year results and found an effect for speed training at 10 years being related to dementia risk reduction with a hazard ratio of 0.71. This was just barely significant, but again, it's a very promising result that needs further study, and that's what we're doing. This next slide, just to kind of summarize the dementia findings, we're looking at the 20-year outcomes now. We have diagnosis of dementia through the Medicare claims records, and we are hoping to have something on that out soon, looking at long-term effects of training on dementia outcomes. So in this next slide, this is the FINGER trial, which is the Finnish geriatric intervention study to prevent cognitive impairment disability. It was one of the first large multi-domain interventions to try to prevent dementia, and this involved various training components like various intervention components like nutrition, exercise, monitoring your blood pressure, as well as cognitive training. And this was the last component in this intervention, which ran over 2 years. And they've gotten some very promising results from this intervention on the cognitive outcomes, and particularly on executive functioning ability. They're doing a longer-term follow-up. This study is out of Finland, and it's one of there are several similar studies now ongoing, like the US Pointer study and others that are looking at these kind of multi-modal interventions. And so I'm almost out of time here. I want to leave some time for questions. In terms of summary and future directions, I think long-term follow-up studies are critical, like the 20-year outcome study. I think we need to try to embed these interventions into the complex lives of people. Multimodal interventions that certainly need further study. We need more assessment that it includes biomarker assessment to try to get underlying mechanisms of training effects. And finally here, a broader conceptualization of our approach to cognitive training and engagement, and really taking advantage of learning and cognitive development principles that we've learned from children's learning and learning into emerging adulthood, and applying those into cognitive aging. And the next slide here, just to kind of repeat the multimodal interventions, you see examples here from different approaches that try to combine interventions, and then these immersive learning experiences like Experience Corps that we've been involved in that involve older volunteers working in the public school system with young children to try to improve academic performance and classroom behavior. And this next slide, you see, I won't go into all the results from Experience Corps, but we have found some very interesting findings in terms of changes at the brain level, improvements in hippocampal volume for men, and some improvements in women for those who have been involved in this very intensive kind of high impact volunteer program for older adults, which runs, these older adults were in the program for a total of 2 years. So it's a kind of a massive dose of interventions, 15 hours a week or more. And we're actually doing a 12-year follow-up of these volunteers right now to see what the long-term effects are of this kind of intensive volunteering. And then I just want to mention quickly next this CALLA model, which is a new conceptualization we tried to come up with to look at learning as it occurs in the real world and to try to develop a model that sort of tries to account for learning in the real world. And this next slide is just the CALLA conceptual framework, and trying to identify factors, broad learning factors that may be put in the service of older adults as, sort of more for broad learning, not just, when we're young, we're adapting to novelty, we have new experiences, novel input, but as we get older, there's societal pressure to specialize, and we may be less adaptive to novelty and new experiences. And so we're trying to put into practice some of these broad learning principles, such as having a growth mindset and having a serious commitment to learning and learning multiple skills simultaneously. And you see next, we published a paper this past year in Journal of Gerontology where we reported results of 2 studies that tried to teach simultaneously older adults skills like drawing and music composition and iPad use and learning to speak Spanish and multiple complex skills like that simultaneously. And we found improvements in both these studies with groups of older adults, improving to the point here, this is a cognitive composite score of working memory, cognitive control, and I think executive functioning. And you see that their performance improved to the average of middle-aged adults on these cognitive outcome measures as a result of this intensive multiple real-world skill learning experience. And so I'll end here with the question, and so does cognitive training work with older adults? The very simple answer is yes, but numerous research trials, including active, show immediate benefit. But, and this is a very big but here, lots of questions remain about who benefits, practical impact of benefits on everyday tasks, how long effects last, whether or not it can prevent Alzheimer's disease or help dementia patients. And so what I think we need, as we see in the next slide here, is more of an engineering level understanding of cognitive training program, particularly I think as we go to these more multimodal interventions and start to combine different pieces of interventions, how those all fit together and how this works as a more sort of engineering level of understanding. And then trying to look ahead to what's next. Finally, I think a large primary prevention trial involving diverse at-risk older adults would be something I think could really help advance the field. Head-to-head comparison, I think, are very important. I know Dr. Charnas and Dr. Boot and others are involved in this ICE-ACT trial, which is a good example of that type of approach. And then and combining cognitive training with some of these broader learning principles that I've talked about, optimal dosing and getting at underlying mechanisms of transfer. So I think with that, I'll just thank all my many collaborators on these different projects and at Johns Hopkins and at other universities, and of course, acknowledging again the generous support of the National Institute on Aging and other funders. And finally, here's my contact information. I'd be happy for any of you to reach out to me if you had any questions about any work I presented today. So thank you very much for your attention.
And thank you, George. Very much appreciate that. And sorry, we're running a little bit late. I hope people can stick around for a little while because we had just a few technical difficulties at the beginning, getting up and started. And so I want to open it up to questions if possible. Some of them are some of the questions in the chat. Mm-hmm. If not, then we can, so if people will raise their hands, I might be able to get questions that way. But if we can get questions through the chat, that would be helpful. So actually, I see any here, any evidence on nutritional factors?
Yeah, that's not been sort of an area of focus for us. I know there's a lot of work, active work being done in this area. I think certainly the finger trial, had nutritional counseling as part of that intervention. I think it's certainly something we should pay much more attention to. And cognitive training, you have to think of not in isolation of these other factors like good nutrition, good sleep hygiene, stress reduction, good exercise habits. So it's all sort of part of, just good health practice in general. And so there is evidence for certain, nutritional supplements, but that's not something that we've really included in our work, but needs to be done.
Thank you. I've allowed people to unmute themselves, but okay, here's another, we have some questions coming in. How difficult is it for people to sustain new learning habits?
How difficult is it for sustaining?
Yeah.
Yeah, well, it's very difficult. And I think this is an issue that we really need to face head on in this area. And actually, Dr. Boot and I were chatting about this a little earlier today, how, this initial enthusiasm for cognitive training seems to tail off pretty quickly. And, it's just like physical exercise, people want to do it. They start to do it, but then they often have difficulty sustaining it. And so I think we need to find, ways of motivating people to continue. I think adaptive training is important. People quickly tire if they're sort of just seeing the same sort of level of training all the time. So I think to the extent that we can adapt the training and make it, continually new and interesting, and multiple levels of training, I think that's important. And I think that, it's important to know why people signed up for training in the first place, what's motivating them to do the training, and then try to tap into some of those motivational factors. With Experience Core that I mentioned very briefly toward the end of my talk, one of the motivations for older people to sign up for that trial was to make a difference in the lives of the school kids and to make a difference in the lives of their communities and neighborhoods. And so that was a very strong motivation for them. And our retention rate was very, very high. And they continued in the Experience Core for 2 full years. And they often went after leaving the Experience Core to go on to volunteer and be civically engaged in other ways. And I think that maybe there might be a way of tying some of these interventions to some sort of broader social good or broader purpose or meaning than just sort of training, sort of one-on-one individually. So I think there's just a lot more work has to be done on sustainability, adherence, tolerability of the training. As people, you get tired of doing this. I know, I do this work all the time, and I've started different cognitive training programs myself, and often don't, keep going with them. So it's a problem that I think we all share and need to think creatively about, how to sustain effort.
Okay, a couple other questions in. Any current studies for persons 50 plus to participate in?
Yeah, I mean, I think more and more you're seeing us starting to recruit at younger and younger age periods. I know, when we started out with active, we recruited 65 and above. And then we did a follow-up study where we did a computerized version of the active memory training intervention. And we had so much interest in people in their 50s with cognitive training that we actually lowered the age eligibility level, and started training people in their 50s and above. And I think, we're increasingly, we know that cognitive changes occur across the lifespan. Many of these, changes start to occur very, very early in the lifespan. And so the earlier we can get started, the better. And so I think, you're seeing multiple, studies being done where they're doing it with lower and lower age groups, particularly people who are already at risk, have multiple risk factors like being sedentary or having high blood pressure or other factors.
Lots of other questions, but we are kind of running a little long, so maybe I'll just ask a couple.
Sure.
Do programs such as Lumosity, crossword puzzles do any good?
Oh boy, that's a tough question to answer. I mean, as far as we know, they don't do any harm, unless maybe you do those to the exclusion of, doing anything else, not maintaining your social relationships, or, there is an opportunity cost to, doing this cognitive training. If you're going to do it 24/7, that's probably not a good thing. I think that, there again, it kind of also depends on, the individual who is doing that training, how long they're sustaining the training, and there are lots of, other factors involved. I mean, I think people should.
Sorry, let me, one second, George. I had to mute out someone. Let me allow you back in here. So I made you host. Do you want to unmute, George? Sorry.
Yeah, okay. Now can you hear me?
Yeah, perfect.
Yeah, okay, yeah. Now, as I was saying, I think, any training program that you are thinking about undertaking, you should really, do your homework on the program, see if there's, if there's independent evidence supporting the program, and, what effects have been reported, and, not just look at it in isolation of other, good health practice that you want to engage in.
Okay, I'm going to end with one last question. It's on a lot of people's minds. What's the probable effect of our serious and long social isolation, perhaps only with our spouses?
I didn't catch the last part of that, Neil. I'm sorry.
Okay, so what is the probable effect of our serious and long social isolation because of COVID, presumably, perhaps only being able to interact with our spouses? So it's a loaded.
Yeah, well, I know it's hard to predict, how this is going to play out. I think, this is certainly a concern that, we're becoming increasingly socially isolated. We may not be as physically active as we were pre-COVID. We're not, doing things to get out and stimulate ourselves socially or cognitively or physically. So, I mean, I think it could have a potentially very detrimental impact, not only on older adults, but people, across the life course. But on the other hand, I think it represents an opportunity that, people have been learning to, go online, use Zoom. They report more free time to do things that they haven't had time to do before. And, there may be some benefits as well to having this, maybe in some cases extra time. So I mean, there's just, lots of research being done on this right now. I just don't know. I guess it depends also how long this drags on, and what the outcomes are. But I certainly think it's not doing anybody's mental health any good. Let's put it that way. I mean, if you look at rates of depression and suicide and anxiety disorder, the rates are just skyrocketing. So it certainly has had, I think, a detrimental impact at the population level.
although I'd add the point that some of the studies so far are showing the best protected group so far has been older adults. in terms
Right,
of
right.
stress levels and
Yeah. Mhm.
anxiety,
Or
depression.
bubble, yeah, maybe a less change in, their lifestyle than somebody who's out
Okay,
working all the
well,
time.
as I said, we run a little bit long. I want to thank everybody who showed up today to listen to what I thought was a really engaging and very informative talk, certainly meeting with the mission of our institute. George, thank you so much for presenting. Our
My
audience,
pleasure.
it was, I think, about 127 people at full range. It was terrific.
Terrific.
And, I hope in future we'll all be able to meet with our speakers. Normally, we would invite you at this point to an hors d'oeuvre and drinks session after the speaker to be able to engage with them individually. We can't do that today, unfortunately, but we hope in the future we'll be able to resume our in-person meetings. So a round of applause for George and also to our audience for being so engaged and helpful with questions. Thanks again for showing up.